Thank you, everybody. Welcome to the Finance and Planning Committee meeting, and I'd like to also acknowledge our new director is here. And so thank you, Director Sai, for attending today. And we'll call the meeting to order and call the roll.
Sure, I'll start with you, Commissioner Chow,
Yes.
Commissioner Guillermo, and Commissioner Guggenheim. Great, welcome everybody. I will read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. We can move on to item 2, the approval of the February 10th, 2025 committee meeting minutes.
So, Commissioners, the minutes are before you for approval. A motion is in order.
I move approval of the minutes.
Second.
Is there
And
public comment?
there's no remote public comment. Is there any public comment in the room on this item or on the minutes? No public comment. So all those in favor?
Aye.
All right, thank you. The minutes have been approved. We can move on to item 3, the monthly contracts report. And I believe that Director Sai had something to say. Give me 1 second to turn on your, yes. Okay,
Can you all hear me?
yes.
Okay, good afternoon. Today, as Commissioner Chow mentioned, today is my first day in the role, so I'm very pleased to be here. And I'm, I guess, 5.5 hours in. So thank you all. The team will be shortly presenting some contracts for recommended to move forward. I wanted just to say one quick note. It is my first day, so I have many caveats. The team has been excellent and is briefing me on the range of things before the department. One of those is a range of contracts up for extension, renewal, or any sort of other action. And I and the leadership team and staff at DPH will be taking a look at all contracts, particularly those that are coming up for various actions. Our goal is to make sure we can support and sustain sufficient treatment capacity in the system, but also make sure we have sufficient transparency, accountability, focus on outcomes, focus on metrics to make sure that we are effectively, with our providers, serving the people that we in the community. So you'll hear details around some of the contracts. One of the larger contract that you'll hear discussed today, the dollar amounts and the time extension you'll see put before you, I want to make an important note, which is with the team, we will be quickly diving into some additional performance oversight pieces that we would anticipate adding to the contract. It's a contract extension before that is executed. So today, the team will talk through some of the monetary pieces, which are important because we do not want to have any gap in services and care and treatment for the people we serve. But I want to assure you and note for folks that we are taking a very hard look at making sure our contracts have the right oversight, accountability, and other pieces. So it is my first day, so I wanted to say that, and we will be doing that work very rapidly. So I think with that, Mark Michelle from the team will be coming up to walk the commissioners through the contract details. Thank you. Good afternoon.
Thank you very much. And Director, we appreciate your comments, and these are very much in line with our Finance Committee approach. And we're happy to hear that this is not only going to continue, but be actively pursued by your office. So thank you very much.
Terrific. Thank you.
Hi, good afternoon, Michelle Ruggles. I wanted to introduce Phil Mock to you, who's going to present the first contract and then on an ongoing basis. But he replaced Dean Goodwin, that have been here will know, and is the director overseeing in the contracts office, the community-based organization contracts, but also serving as the representative for the Health Commission. So with that, I'll introduce Phil Mock, who will do the first contract.
Hello, commissioners. It's a pleasure to be here. Again, my name is Philip Mock. I'm the manager of CBO contracting. The first contract that's on the monthly report is the registry network. The request today is an amendment to a multi-year contract with the registry network to provide as-needed temporary radiology registry services to the SF Health network. The approval of this request will add $3 million to the contract, due in large part to a surge for the need in these services, staffing needs, and vacancies. The current contract is expiring on 12/31/25, and the term will remain unchanged. The Health Commission last approved this contract in December 2022. Please let me know if you guys have any questions on this particular contract. I believe the commissioners had some questions about the experience over the past year. On the call, we should have Sabrina Robinson, the Chief Operating Officer of DSFG, to answer that question and any other questions you guys may have.
And Commissioners, I also put a written response from Sabrina or Ms. Carpenter in front of you. And she's obviously here also remotely in case you want to ask any more questions. Is there any public comment? Actually, we're not ready for public comment on this item. So Commissioners, please ask away.
That I'm not quite sure whether my questions are dumb or not, but according to this, the amendment is to add $3 million to the original contract. Is that right?
Yes, that is correct.
And that's because expenses are higher, we want to cover more?
Yeah, there's been an increase in the need for these services, and there's also been staffing level challenges. There's been some leave and also issues of hiring new radiology techs.
I think in follow-up to the commissioner's question, could you also then respond to the fact that since it sounds like, we've heard nursing as well, position. Is it that the area in radiology technology, the technicians were lacking and therefore were substituting, or there's been an increase in volume? Or what exactly caused, the need for the extra? And how did you determine 3 million on top of a $5 million contract? Because that's more than 50% more.
Thank you for that
With-
question, Commissioner Chow. So we did the expenditures for this contract, and it looks like there's been an increase year over year. Based on the analysis, it seems that if we add an additional $3 million to this contract, it would take us through the end of December 31st of 2025. As far as the vacancies are concerned, I will defer that to Sabrina Robinson, who should be able to answer that question for you.
Sure, Commissioners. Thank you for your question. So I'm going to answer the question with regards to the vacancies and also about the volume. So currently we have 7 vacancies in the radiology department, and we have also six people on leave. So together that's 13 vacancies in that department that disseminate across multiple modalities, including ultrasound, MRI, X-ray tech, CT, and breast imaging. I will also mention with regards to the volume, year over year, we have increased in all of the modalities 6.1%, and over the last 2 years, 15%. And so we are trying, even prior to the hiring freeze, it was difficult to find these individuals for permanent positions, which is why we needed the registry staff, and thus the reason for increasing the contract.
Commissioner Guggenheim, does that satisfy your question?
Yeah, thanks.
Thank you. Commissioner Guillermo?
All right. So
It also satisfied my question. And so if we have no other questions, we can move on to the next contract.
Sure. I want to first apologize to Miss Robinson. I called you Miss Carpenter because there's a singer named Sabrina Carpenter, so you know what kind of music I listen to. So I
Yes.
apologize. Thanks for your responses. Next contract, please.
Okay, thank you, Commissioners. I'll defer to Michelle Ruggles for the HR 360 contract.
Hi, good afternoon, Michelle Ruggles. Okay, so HR 360. So today, the request is an amendment to, this is, as you know, a long-term contract with HR 360 for the provision of residential and outpatient services. The current contract expires June 30th, 25. So this amendment will allow us to continue the contract for 3 years through the solicitation authority of this term. It will also allow us to fully fund the contract for fiscal year 24-25 and then continue at the current level through the end of the term. This was last presented here in June of 2022, and we'll be taking this subsequent to this, to your approval, hopefully, to the Board of Supervisors for approval. Let's see. Included in your packet of information about this contract, you received a separate unit of services and projected unduplicated client count for each program. And then we provided the monitoring reports that were not still in draft. But if you looked at that Excel overview, we provided the scores so you would have an assurance that they're doing well in all of their programs. And so the draft follow-up is that the vendor will sign it and then we'll have it. But in case there was anything to change, I'm sure the scores won't go down. But that's why you didn't get the actual report, but we wanted you to see the scores. And you also have 2 fiscal monitoring documents. Both of them are standard that you've seen before. One of them is the citywide fiscal and compliance monitoring report. And then the other one is the separate report that is completed annually by the Business Office of Contract Compliance, who does an audited financial statement review against multiple criteria. So both of those showed that HR 360 was in strong financial standing and at the time of the report at low risk assessment. And then we had some follow-up questions, and if I forget one, sorry, and please let me know. So one of the questions was the projected or the unduplicated count. So I was able to obtain the unduplicated count actuals for fiscal year 23-24. So in the outpatient, it was 646 people, and in the residential withdrawal management and step down, it was 3,000 or 3,053. So in 23-24, the unduplicated count within those programs was 3,699. And there could be some crossover of people going to multiple programs, but that was the report out. Did I miss anything that you requested?
We'll have additional questions for that.
Okay.
Let's find out. Oh, that's right. We're doing contracts, so
Yeah. Well,
we can proceed with questions.
sure. Well, I'll just check to see if there's public comment before you all do the final questions, because this is the last contract.
Okay.
Is there any public comment in the room on this item? No public comment, so you all are clear to go.
Okay. So Commissioner Guillermo, please.
Thank you, Michelle, and welcome, Phil. Wherever you
I know.
see you, but welcome. So I have a few questions. So regarding the contract, I know from last time, the city attorney has asked or directed that contracts be separated by solicitation. So all of these programs under this contract are under one solicitation?
They're under 2 solicitations. So there's 2 mental health outpatient programs
But this is just one contract that's being presented.
This is one contract that's being presented that has all the programs in it that all the information you've received is just about this contract. And when we go out to bid, the bulk of this contract will still be together.
Okay, when will that be?
The RFP for the substance abuse ends in 3 years. And so that's when we
So-
would go out to bid.
All of these same programs will be under that solicit. It's still just confusing sometimes when we're talking about sort of retro agreements and future solicitations. So
Yeah.
if you could just,
So this one's not retro, this
or,
contract?
yeah, the amendments, I guess. Yeah.
Well, the amendment, yeah, okay. The amendment's not I mean, it will be retroactive, but they're not out of, like, it's still, the current contract is this term. So we're not asking retroactively for an amendment. It will, once you do an amendment, it will go back to this fiscal year. But it's not, sometimes an amendment, the contract is ended and we're extending it. So right now we're still in a live period, if you will, through June 30th.
And all of these programs are in this contract are under a previous solicitation, and the new solicitation will happen at the end of this contract period.
Yeah. So there's 3 types of programs in here. There's outpatient programming, residential treatment programming, and there's a little tiny rep payee. So the outpatient and the rep payee will have a different solicitation.
Okay.
And the residential treatment is about 80% of this contract. So eventually, when this contract goes out to bid, there's a possibility there'll be 3 separate contracts as opposed to this one,
Because the solicitation will be different.
because the solicitation would be different.
Okay, but we don't anticipate that until, if we approve this, then we don't anticipate that
No.
solicitation until
Right,
the end of the contract.
yeah.
Okay, just wanted to make clear about that. And then the monitoring reports, some of them don't have finalized dates or report dates. So can you explain that a little bit?
I'm looking at the summary, and so sorry because I didn't print out the actual monitoring reports. The fiscal year 22-23, I think is what you have, and those should be signed. The 23-24,
We don't have any of those.
yeah, okay. So those are the ones that are in draft, and we should be getting those back. They've been drafted. They've gone out and done the monitoring report, but there's a period of time where the program can comment and make changes. And so, or whatever, follow up. So instead of providing those while they were still in draft, we gave you the scores in this Excel document. Does that answer what you're asking?
Yeah, it's just because there's more detail on the ones that have been submitted,
Right.
and it makes it difficult then to make a determination of the detail, the progress based on detail if we don't have even the draft reports. And then again, some of these 22-23 monitoring reports, as I said, don't have a finalized date on them, even if they're signed. So I don't know if that was just an oversight.
I think it was an oversight. It would be by the date that's on the front of the,
If we could just be more consistent then about.
I'm
the-
not sure why it's
yeah.
not, but yes, of course.
Okay. One last question on the performance objectives. I think this speaks to Director Tsai's a comment preceding the review. The performance objectives are developed, are they primarily from the state Medi-Cal funding, or are they also the department developed performance
I
objectives?
think it's a combination. It's 100% includes what the state requires. So we have performance measures that the state measures us on, and we have performance measures that the programs have added, like across the board, they'll develop them, and sometimes they're not led by state requirements, like for Medi-Cal, for example. So I think there's add-ons, but there's also everything the state requires or federal for meeting Medi-Cal or funding obligations we capture.
So the performance objectives that that the director mentioned are that are going to be worked on throughout this period will we get a sense of what those are going to look like so that we don't have to wait for 3 years before we get a chance to?
Yes. So, excuse me. Thank you, Michelle. As I mentioned, I've directed our team to quickly take a look at all of our contracts, but including the ones right before us. So the commissioner, the one you're referencing, and to make sure we are adding strengthened oversight measures. The team will be doing that very rapidly, given the funding is required to make sure we can continue services. But I think we would be happy to circle back on those. They will be things that allow us to make sure we have metrics and line of sight into the clinical performance and what is happening with both this provider and frankly any provider. And so if part of your question is, are we thinking about additional new performance measures or monitoring metrics that we might need? The answer is yes. We're going to do it very thoughtfully, very collaboratively, very quickly. But we think that's important to make sure that the contracts have strong fidelity, there's accountability, and we know the outcomes that we're getting. Does that answer your question?
Yeah, it does. I think part of my worry is, given the federal environment with impending Medicaid cuts, how that might affect the objectives that are in place based on what we would be approving. We don't want to have any gap in
Right.
funding, and we know how challenging
Right.
these programs already are.
Right.
And so will we be considering I guess, even more challenging future, given we don't know what the cuts are going to be like and how that's going to affect the department being able to develop objectives and then hold the service providers in partnership to them. Yeah.
I think those are great points. I think those are great points the team will be thinking about very rapidly. And I want to stress for the contracts before us right now that the team has been working on, this is not a 3-month exercise. We may take a broader look over the next year at some of our contracts, but for the contracts that are up before us right now, we want to make sure we identify a handful of priority things that would be important to add in at renewal and to get those in very, very quickly. So we're talking about very quickly, not over the course of many months looking at things.
That's reassuring. Thank you.
Thank you.
That's all my questions.
Commissioner Guggenheim?
I'm not sure if this fits in with it, but I noticed that in the first one of the HR 360, it says the program failed to submit the program declaration of compliance. I have no idea how important that is, or it wouldn't be there. Or...
Yeah, and some of that's the draft and coming back, but the program declaration of compliance is essentially a list of all the compliance activities that they must comply with, from like posting grievance posters to having an administrative binder with copies of all of the policies. And it's a whole bunch of stuff. They get a point, or maybe it's more than 1 point. It gets sent out to them, they sign it and turn it back. So they get a point as an incentive to acknowledge that they got it. But even so, that gets checked during the monitoring. So they open that up and go through the declaration of compliance checklist. So they're still getting checked. They just didn't get the point for turning it back in, which we want them to do.
Okay.
Any other questions?
No. Thank you.
Well, Michelle, I am looking over about 3 of these spreadsheets, so I'm really confused. Each one are supposedly the same, except that some of them don't have a back page. So now I'm realizing, going back to the one that I was sent in the original packet, it
Uh-huh.
has 2 sides. And now I understand why we don't have some reports.
Right.
Uh, because in very small print, it says fiscal year 23, 24. And others are 22, 23. And most of those have reports. So I think I figured that out.
Okay.
But now, are all these, since I am assuming that my first 2 copies here and the one that I printed out only shows one side, that this 2-sided program list is what we're voting on? It's 2
Correct.
sides and
Yeah.
it's got more items on it than just a single one side that was what I printed out.
Right. Correct.
Okay, and in that case then, I see. So the final page, not knowing which side, it'd be nice if we numbered these pages 1 and 2.
It would be nice if what?
But
Page
it would be the one that begins with, or has on the bottom payers, services, and withdrawal management. Okay, so
That's the
Yeah,
backside.
there was your
that's the
question.
backside. Okay, thank you. Uh, Those have reports coming from 23, 24, so that's why we don't have them, right?
Right.
And they are part of the contract.
Everything on here is part of the
Oh,
contract.
okay, that's what I want to clarify.
One, you just reminded me though, by calling this out, you had asked a question about why the programs were separate. The reason that they're separate is because one of them gets reported on separately. It's federal funding. And so sometimes when there's sometimes when there's a specific funding source, the program pieces will be pulled out so that there can be ease of reporting back to the funder. But I think your question was on the residential, it's funded by SubG. It says SABG. I think they've changed the name to SUBG. But I could let, if that's still a question, Christy Soren, Dr. Soren, who's our Deputy Medical Director for Substance Abuse Services, if you'd like, she can speak to any of the programming questions.
Well, I'm just wondering, because some of these all, sound fairly similar and they may be in different locations, but is that a reason we have different contracts? And this was a very confusing contract to read, and all these contracts that we have coming through, because I think it is so broad. And this is one of the problems with the issue of Health Right 360. I've gone through full circle, whether we're going to have individual contracts, and I see you're smiling, you remember that. And then we decided to lump them all together so the contractors and everybody could review them all, and we know what they're doing. And then now that we're reviewing them, we have a whole bunch of services that are really making it very difficult for us to understand what we are actually all doing. And when we see the fiscal report, I mean, these people have dozens of contracts from us and from the rest of the city. And it's nice that the 360 finance have turned around somewhat, but we always get somewhat concerned because for several years they really ran in the red, and we, we're very concerned about their viability, right? And so just with a 1-year positive, or it makes it a little iffy to us to say, well, having come through with 1 year, how do we know that they're not going to go back into the other? So that's going to be a second question. I still want to try to find out that we have an opportunity to really kind of help with what the director was talking about, sort of thinking out how we can better understand the programs that are coming before us. And what we want really is, could we understand there's this program and this is what happened. And, you know, the state has all these other performance metrics for some of these things, but much of that is process. And what we're really all looking for is also outcome. If so many people went into this program and it was supposed to create opportunities to do that, how many people actually did that or got to that? And of those people who then got to that, how many were successful? That then tells us that the product, that the program is valuable. And while it's important to go through and be sure that in detail, you know, they're managing well, you know, they have the right personnel and so forth. We've been in this situation trying to still understand, even with the volumes of monitoring reports, did these people ever get, oh, let's just say it was a work program. Well, did they get into work? And how many actually stayed in that job? Or if it is to become sober, and how many stayed sober? And while it's longitudinal and there is a problem because it's outside of the contract then to find out, be nice to figure out how we could really do that, because the ultimate for the program is we want so many people to get sober and be meaningful, citizens here, and also have a better life. But how many of those people did that? I don't think we can tell from even the 11 contracts, except for the fact that, you know, under the payment contract, they did well. And I guess that's where I'm really trying to get to. If we're going to review these, that is there a way that we could understand that after 2 or 3 years, and we've had 2 or 3 years at least of this contract, that it's not just looking at the process and whether or not they filled out X, Y, Z, and, they had all the employees, but in whatever the objective was, and it's not always clear in here what the objective was, did we meet it and how do we meet it?
I'm going to let Dr. Soren speak more on that, but I do just want to say one thing about that we're really aware of the fact that we have a lot of process objectives and the desire. We've had different audits, and that's a finding to come up with more outcome objectives. And so right now we're working with the controller and internally with our one of our teams looking at that process. So it requires a very concentrated effort, and I think that is I know that's the direction that we're going, to look at those and try to come up with objectives that can be measured. We're also doing this or thinking, planning this out in the context of all the changes that are happening under CalAIM and how we're reporting. And so making sure, that's the other big piece, is being able to design objectives that are measurable and that we have reports. So I absolutely believe that everyone is working on that, the controller's office helping us to get there. But and I also know they've been doing a lot of work on that topic. So I'm going to turn it over. Christine.
No, I appreciate all the work that's being done, and the fact that we have to go through the process measures. And so I guess we're still looking at, and one day I'd like not to be able to have to read the process measures. I mean, Michelle knows at one point we had a dearth of information, and now we have almost too much information. That then we're in the middle of a forest and we're kind of missing, well, we're in the middle of trees and we're really missing the whole forest. As to getting a feeling that these are really good programs, and with the hundreds of millions that are being spent, that they were worthwhile. And for these nearly 3,500, 4,000 people, we helped them.
Yeah, yes, my name is Christy Soren. I'm the Deputy Medical Director for Substance Use Services for Behavioral Health Services. Hopefully I can elucidate the forest and also explain some of the trees. Maybe first I'll do a really brief overview of the program because you asked a couple questions about withdrawal management and some of the other levels. So Health Right 360 is our biggest substance use provider in the city. They have every level of care from the least restrictive, the lowest barrier to entry, to the most structured, to some of our residential programs and beyond. So included in that includes outpatient substance use treatment, intensive outpatient substance use treatment, that's extra hours and someone has to have a more severe disease to reach that level of care. They have withdrawal management, which is often the place where someone goes as they're withdrawing from substances to safely then enter treatment in a residential treatment program. They have 3 different levels of residential treatment, and these are all levels of care that the state and national organizations determine. And so within a residential program, it may depend on how much structured programming there is and how much staff support there is. And that's determined by the patient's severity of disease and other psychosocial factors. And then they also have residential step-down programs or transitional housing where someone can go after residential treatment to really continue to work on their substance use while they're also getting connected to a job, getting education, and also getting outpatient treatment provided in that residential transitional housing. So we're really grateful for Health Right 360 to provide all these comprehensive services, and that comes with a lot of complexity in the contract. We also know that some of the findings that you'll notice in some of the reports that they've done progress on, and I'm happy to comment on any of those specifics. We've also been working really closely with them this past year and have progressively increased how much supervision and monitoring and oversight of this contract we've done, including starting with weekly visits to now we have an agency technical assistance program that we're doing, process that we're undergoing, in which we meet weekly with the program, are conducting weekly site visits, and have outcome metrics that we're tracking related to safety, quality, and staffing. I don't have those in front of me today and would be happy to come back and report on some of those. The business of office compliance contract monitoring really measures those process outcomes that you allude to, but we also want to get to some of these outcome measures. How do we know that people are getting better, which is the biggest thing that we're asking ourselves? That's a brief overview. I'm happy to answer more specific questions too.
Well, for me, that was very helpful, and I really thank you. And I wish the documents could have given us some sort of perspective on this as we were looking more in detail. But commissioners, did you have any comments in regards to my general comments? Yes.
So off the top of your head, and because you're a professional, is it your sense that the outcomes are really good in these programs?
It's a great question. So they do a wide range of services. So some things we think about that we think about nationally are good outcome measures are people engaging in medication treatment when that's appropriate? Because we know people tend to, it reduces risk of overdose. People tend to use less or stop substance use, and they are meeting that metric generally. Another one that we look at is after someone is engaging in these higher levels of care, such as residential treatment, are they connecting to the next level of care? Because we know someone can spend a couple months in a program, but what matters is what happens when they leave that program? What happens when they're reintroduced into the community they were in prior? And overall, the program does well in that as well, connecting people to outpatient treatment and residential step-down treatment too. Beyond that, there aren't a lot of standard metrics in substance use treatment that we look for. Or that nationally are set standards that the whole country is looking at. And so we also are diving deeper into what's happening in their programs. In particular, in their residential programs, are people engaging in the services and getting enough hours of clinical services and psychoeducational services, and they're meeting and exceeding the state standards in that. And we just recently looked at that metric last week. In addition to that, we're also looking at engagement in medications while they're in programs, as I mentioned too, as well. So my general sense is yes, but I'd love to come back with you with actual specifics so you could feel some confidence in that answer. And maybe that's the next meeting.
Thank you, Commissioner Guillaume.
So I really appreciate that overview, and it made me think that maybe what we can do in the future, if there are amendments to large contracts, and I don't know the amount yet or the number of programs under a particular contract that might be the baseline for this, but to have somebody programmatically do that overview and, before we actually ask our questions, because otherwise it does become more of an administrative piece. And we've been asking for a while now that the connection between the programmatic services and their efficacy, effectiveness, the question that Commissioner Guggenheim asked, and the monitoring, of administrative compliance, we're still not able to make those connections. Um, and I know that for large contractors, a lot of the pressure that gets put on having to comply with all of those is an important piece, obviously, right? But the programmatic is what we're really looking for. And for large contractors, super large contractors like Health Rate 360 that are willing to take on the whole compendium of services and sort of be both the model as well as take the brunt of the criticism when things don't go exactly as planned. It's important for us to be able to make those connections between either is the administrative burden too high? Are the programmatic objectives not appropriate? Do they need some change? Or is it just we're lacking an overview? So those are the kinds of things that would be really helpful when we are looking at or being asked to recommend approval for large, I mean, not to say that the small contracts aren't important, but we are talking about hundreds of millions of dollars and thousands of lives here. So I think that was really helpful. Yeah.
Thank you. Do we have any other questions on the Health Rate 360? Any questions further? Okay. So I think we're prepared to vote on the contracts report.
Yes, so the motion would be to recommend that the full commission approve.
So motion's in order.
So I'll move recommendation of the approval to the full commission.
Now second.
All those in favor?
Aye.
Right, thank you so much.
Aye.
All those presented. We can move on to item 4, the request for approval of a new professional services agreement with Crestwood Behavioral Health. I believe Dr. Pading and I may.
Hi, good afternoon, Commissioners. My name's Emma Garcia. I'm the Program Manager of Mental Health Residential, and I'm going to provide an overview of the service that we're pursuing today. If I can log into my computer, that is.
Oh, would you like me to pull up the presentation?
Yeah, if possible.
All right, 20 seconds, Commissioners. Okay. Please begin.
Do I drive on this one?
I have it.
Oh, great. So I'll just start with some brief background on this project. In 2019, Mental Health San Francisco required the city to establish a mental health urgent care center for people experiencing psychiatric crisis. We believe that our proposal today is the response to that. And we're seeking approval of the contract with Crestwood Behavioral Health to operate the new stabilization unit at 822 Geary. 822 Geary is expected to launch in 2025 this spring, and the building is currently under renovation. The service itself will provide immediate voluntary medical care for people with urgent mental health and substance use needs. The stabilization unit will operate 16 beds, 24 hours a day, 7 days a week, and it's going to be staffed by medical professionals to treat people with urgent needs that do not require a hospital emergency department. The stabilization unit is a DHES certified Medi-Cal reimbursed program, and we also have engaged community ambassador services to contribute to community safety in the immediate neighborhood. The staff requirements for this service require that a physician be at a call at all times for the provision of those services that can only be provided by a physician. Also, a minimum of 1 registered nurse, psychiatric technician, or licensed vocational nurse to be at sites at all times when clients are present. That minimum, our ratio is 1 to 4. And for staff that we're considering, that are considered licensed mental health or waivered registered professionals. Our site is going to be staffed by a total of 37.1 direct service FTEs and 3 indirect staff. I'm moving pretty quickly, but on the other slide, I just want to talk about the community engagement that we did beginning in 2021. As we mentioned, this was initiated by Mental Health San Francisco. So we did a lot of work in working with the Mental Health San Francisco Implementation Working Group when we designed and developed this program in 2021, 2022. We also did a lot of review and discussion with first responders, the fire department, local police, local ERs, and EMS. We also did outreach and reviewed similar services across the state to see if this would be the ideal service for our city. Initially, we also did outreach to about 20 businesses about a year ago to inform them that the service was coming as construction began and broke ground on the site. Since April of last year, we've been doing ongoing community and local neighborhood meetings with neighborhood groups and stakeholders. To date, our department has met with over 20 stakeholders and community groups. I'm sorry, we've had over 20 meetings with community stakeholders. And as we onboard Crestwood to be our partner, we plan to do more community outreach to further share information about the project and ensure that we're upholding our commitment to the Good Neighbor policy. In our development timeline, you could see what the building looked like. When we purchased the building, it was an abandoned former Goodwill department store, and the renovations have been happening throughout the years. In 2024, we did our solicitation under RFP for the provider. And in 2025, we're expecting to deliver these services in the spring. Concurrently with this contract, we're also doing what we're calling A22 Geary was, let me back up a little bit. A22 Geary was purchased by the city in 2021, utilizing our City, Our Home funds from Proposition C. The site renovation was funded in part through the California Department of Healthcare Services Behavioral Health Continuum Infrastructure Program grant. The grant restricts the use of 822 Geary to be a crisis stabilization unit. Approval of this contract will also allow Crestwood to enter into a sole source below market lease contract with the city for the site. Crestwood will pay us $1 per month for the rent at 822 Geary. Under the authority of the recent ordinance for the core initiatives to strengthen the city's response to homelessness, drug abuse, mental health needs, and related crisis. The lease and the operator will be coterminous. Termination of one agreement will automatically terminate the other agreement. A little bit about our provider, Crestwood Behavioral Health. The proposed vendor is an experienced operator of crisis stabilization units, crisis residential treatment programs, and mobile crisis response services throughout California. Backed by 24-hour physician support, the programs provide interdisciplinary medical and peer staff working together to provide trauma-informed services within the least restrictive setting possible. They work closely with first responders and develop close working relationships with local hospitals and the community. In addition to psychiatric stabilization, the mission of the facilities is to restore a sense of hope, empowerment, inclusion to the community support, and realize the potential of each client. That concludes my brief presentation.
Thank you. Let me check for public comment.
Sure. Is there any public comment in the room on this item? Yes? Okay, great. So you've got 3 minutes. Come on up. Public comment takes precedence? Yes. Yes, please begin.
Good afternoon, Commissioners, Director Tsai. My name is Simon Pang. I am the Deputy Chief of EMS and Community Paramedicine for the San Francisco Fire Department. The San Francisco Fire Department appreciates the continuing collaboration between our department and the Department of Public Health, and we support the launch of this Geary stabilization unit. We are on track to respond to a little over 130,000 911 calls annually, calls that are responded to by 911 ambulances. The majority of these calls end up in a local emergency room. All of our emergency rooms are overcrowded, which leads to events called hospital diversion. In the month of January, one of our local hospitals was on diversion for 56% of the time. That means 56% of the time, this hospital would not allow an ambulance to transport there. This leads to overcrowding in all the other hospitals, which leads to something we call APOT delays, ambulance patient offload times. In the month of January, on my notes, in the month of January, 42% of all of our transports to local hospitals resulted in a wait of over 45 minutes. That's 45 minutes. That 45 minutes is when we arrive at the hospital to the time that a hospital staff member accepts the care of that patient. The statewide standard is 30 minutes. Again, in January, 1,096 times we had to wait over 1 hour to transfer care to the emergency room. And in 87 incidents, we had to wait over 2 hours. This is really important to us because if our ambulances are delayed at hospitals, it means that we cannot respond to the next emergency. The Geary Stabilization Unit would be appropriate care for a subset of the patients that we take to emergency rooms. The emergency room is not the ideal place for all patients. And we really would like an opportunity to have our ambulance transport to appropriate care. Our street crisis units, which are operated by community paramedics, already take a number of, about 18,000 transports annually to what we consider alternative destinations. The alternative destinations that our street crisis units use most often are Department of Public Health resources, such as Silma Rise, Nor Urgent Care Clinic, Hummingbird. And this would be just one more facility that would be appropriate for our personnel. Thank you.
Thank you. Any other public comment in the room? All right. And there's no one who has got permission remotely, so please, commissioners, go ahead.
Surely. Commissioners, questions. Commissioner Guillermo.
Thank you for your presentation. I had just a couple questions. One, the staffing that is anticipated to staff the stabilization center is just given the difficulty in finding staff, hiring staff, keeping staff. Does Crestwood have confidence that the staffing requirements are going to be met to be able to open in spring and continue?
I'd like to defer that to Crestwood, who's here with us today.
Okay.
Please introduce yourself with your title.
Hi, I'm Dr. Patty Blum, and I'm the Chief Operating Officer for Crestwood Behavioral Health. And we do actually have confidence. I can't say overconfidence, but we operate here in San Francisco already. We run a 54-bed, 24-hour program at St. Mary's. It's the healing center, and it's the MHRC committed and dedicated to San Francisco stakeholders and clients and people who we serve. And we employ about 72 employees at that site. So we are used to hiring, recruiting, training, retaining, occasionally losing, and then rehiring. So we do feel confident we'll be able to staff the site. We do run 2 other crisis stabilization programs right in the Bay Area, one in Fairfield and one in Napa. And so we've also have a really nice, very good network of providers. So our ability to bring in providers, we also are confident that we'll be able to do that as well.
Well, I hope so, because that's, I mean, it's going to make or break, right? So glad that you have that confidence. The other question I had then was on the presentation, it says that the program is Medi-Cal reimbursable, but on the request summary, the funding source is Prop C. So can you just explain how that funding flow will happen?
Correct. We are going to fund it through Prop C as we do our startup, but we are going to get the site certified for Medi-Cal after launch. And we expect to have it do reimbursement in the same process we do for most of our programs, retroactively.
So do you anticipate any problems with the certification for Medi-Cal reimbursement?
No.
Or what might be that, maybe that's a better question, what might be the difficulties in?
We don't anticipate any challenges. We've been talking to our business office, and we feel that this program is on track to be certified relatively quickly once we launch.
Okay, just, just worried about particularly funds that have a federal component to them or that are subject to the budget issues that we're facing right now. But obviously, this is something that's really important. And we want to make sure that, all of the resources are in place to, before the launch in the initial phases, and so that we can have as much success as anticipated as possible.
Thank you.
Commissioner Guggenheim?
So if I understand this correctly, these are not DPH employees. These are Crestwood employees who will be operating this facility.
Correct.
And at some point, everybody has to meet DPH standards, I also assume, or outcomes or something.
Correct.
Okay, that's what I wanted to know.
I know the Crestwood's been in the city, and we've been doing business with Crestwood for a long time. And could you cite some of the effort beyond the St. Mary's where Crestwood has been helpful for the department and that you found satisfactory?
Yes, if I can pull up my notes, but I believe we've been in business with Crestwood for about 30 years, utilizing their services across the state. In addition to their mental health rehabilitation centers, they also provide us services in skilled nursing facilities, which we call sometimes psychiatric skilled nursing, due to their expertise and their capacity to serve our clients who sometimes have more behavioral needs than our average skilled nursing clients. I believe we also provide some of our clients at their adult residential facilities. If I can get to my notes, which I might have lost, I could give you specifics. Oh, thank you. As stated, for over 30 years, we've really been in service with Crestwood. And they do operate the services that I mentioned: MHRCs, skilled nursing facilities, and adult residential facilities. Mostly they serve our clients who are LPS who are conserved clients under conservatorship. And currently they're serving about 190 of our clients in 12 facilities. As I stated, our work with them really spans across the state. We have clients as far south as Fallbrook, and as far north, I want to say Reading. So we've had a long-standing relationship of satisfactory care for all our clients at different levels of care.
Okay, and you've been satisfied. I know Crestwood has been working a long time with this. So could you explain to me then, if we're going to look at Medi-Cal certified, then I had assumed that the dollars we're paying for are out of our dollars. Does that get balanced off, or how is that going to work?
We will reimburse a significant portion of the budget that we're requesting. Right now, we're just asking for the total budget as we're starting a new program, and we don't expect the reimbursement to happen immediately.
Okay, I'm looking at if we have a client and we're paying a certain amount of money for the services, right, for the hours. Are those service hours actually just the facility side of it, and the professional side is going to come from Medi-Cal, or we're also paying the professional?
I'm not quite sure I understand the question, but
Try this day one. Let's see. My team can grade me if I answer this right or wrong. Commissioner Chow, I think your question is, if these services are Medi-Cal reimbursable, why would there be any general fund contribution required or other?
Right.
Right.
What's going to happen to the general fund contribution?
Right. And my understanding, which everyone should take with a grain of salt, is that for crisis stabilization, which is there's a state certificate, state level of licensure and Medi-Cal reimbursement. The state will reimburse within Medi-Cal for individuals with mental health and or co-occurring, so mental health and substance use disorder. But the state Medi-Cal program which I only learned of today, does not reimburse in crisis stabilization when it's someone only with a substance use disorder. Obviously, to Simon's point, there are gonna be people that require crisis stabilization that only have a substance use disorder but aren't duly diagnosed with a mental health condition. We want to make sure that crisis stab can handle all of that. So what we are able to reimburse through Medi-Cal, we will absolutely do so, but we're not going to launch a crisis stabilization unit that for some reason cannot serve individuals who are not duly diagnosed with mental health and substance use disorder. So if I answered that incorrectly, the team should, and I don't think there's necessarily a facility or a technical or professional fee around this. It's just going to be one rate. Again, the team can correct me around that. The team is nodding, so that seems like an appropriate response. But hopefully that helps understand anything that's reimbursable through Medi-Cal, we will maximize that. If it's not, we're not excluding individuals with substance use disorder only from crisis stabilization.
Okay, so it sounds like if you're certified and you're able to get Medi-Cal, or Crestwood's able to get Medi-Cal, they're not going to bill us, or we are going to do the billing and then capture that amount for us. I mean, who's going to track whether Medi-Cal is paying Crestwood or the city is?
I understand your question now. We will be paying Crestwood and we will be seeking the reimbursement. So as previously mentioned, if we may serve people who are ineligible to receive Medi-Cal, but we still intend to serve them as San Franciscans. And the Medi-Cal reimbursement may not be 100% match per match, but we typically anticipate it to be at least 50% of the clients that we serve where this can be recouped. It's usually higher, but we.
Okay.
Yeah.
So this is also one of our problems in trying to understand the contracts is how much gets reimbursed also. If in fact, like you were saying, it's going to go on to Medi-Cal, then it may not be that it's going to cost us the full 8 million, right? And
Yeah, hi, Michelle Ruggles. I just wanted to add, because this is a startup, it's a first year, the caveat about the substance abuse not being reimbursable and then wanting to get it started fully funded. That's why it's fully funded by Prop C. When we have some historical information by which we can project how much Medi-Cal reimbursement, then I imagine the next step, and also they have to get Medi-Cal certified, will start to look like like a standard contract that you're used to seeing, where you see the Medi-Cal federal financial participation and then the matching dollars. And so Prop C is local, so for sure that will be used as a match to draw down because we have to do 50-50, and then it'll start to look, but we don't have enough information without having even opened the program yet to project, and we want it to start funded. So it'll look more like what you're used to when we have some history.
okay, thank you, Michelle. I think that was very helpful. Appreciate that. Do we have any other questions, or are we ready for the question? Motion then would be in order to recommend to the commission.
I'll move recommendation of approval to the full commission.
Second it.
All those in favor?
Aye.
Aye.
All right, thank you, everyone. We can move on to item 5, the draft fiscal year 2023-24 annual report. And we welcome Sarah, who's presenting to the commission for the first time. Give me 30 seconds to pull up the report.
Yeah,
Okay.
what do we use the annual report for?
Good afternoon, commissioners. My name is Sarah Newkrug, and I am a health program planner in the Office of Policy and Planning. I'm here today to present the department's annual report for fiscal year 2023 to 2024. The report covers July 2023 to the end of June 2024, so it's just for the fiscal year. As you're aware, the annual report is required by the City Administrative Code, and the report provides a general summary of DPH's accomplishments over the past fiscal year. I'd like to thank my colleagues across the department for their tremendous collaboration in preparing this report. Next slide, please. Oh, sorry, keep it on this one. The annual report opens with a welcome and message from our former Director of Health, Dr. Grant Colfax. Dr. Colfax's message highlights the Laguna Honda recertification process and DPH's work to lessen health disparities and ensure equitable care for heart failure patients. He also described the department's behavioral health achievements and the city's accomplishments with the early implementation of DoxyPEP, which we will showcase more later. Next slide. The director's message is followed by a message from Commission President Green. Her message discusses DPH's response to the Laguna Honda Hospital recertification process and the department's ongoing COVID-19 guidance and leadership. Both these messages provide our leadership's introduction to the department's activities discussed in the report. The next set of sections provide an overview of the functions and services across the department. The sections start by introducing the department's divisions and their roles in protecting and promoting the health of all San Franciscans. The next section reviews DPH's True North and its 6 true pillars, which are followed by the organizational chart. As part of the Racial Equity Action Plan, the report also presents demographic information on both the health commissioners and senior leadership. And these data will continue to be collected and presented in the annual report each year. Next slide, please. The last introductory section focuses on the Health Commission. This section provides an overview of the structure and function of the commission, along with the individual bios for each commissioner. The next section of the report presents 3 feature stories that highlight some of the highest profile efforts by the department from the fiscal year. The first feature provides an overview of Laguna Honda Hospital's recertification process. This feature describes how DPH achieved full recertification from the Centers for Medicare and Medicaid Services, or CMS. Laguna Honda achieved Medicaid recertification in August of 2023 and Medicare recertification in June of 2024. These certifications restored funding sources for nearly 100% of Laguna Honda residents. The recertification process began in April of 2022 when CMS terminated Laguna Honda's participation in the Medicare and Medicaid programs. Laguna Honda responded with a historic and heroic effort that included facility-wide improvements and coordination. The recertification team conducted a root cause analysis of the decertification, which led the team to develop a strategy with almost 1,000 action items, including establishing a new medicine cart system, updating paving, and expanding the resident council. Throughout the recertification process, the city secured more than $200 million of annual federal funding, prevented the displacement of nearly 700 residents, and helped ensure approximately 2,000 city workers retained their positions. Laguna Honda has successfully resumed admissions and is proud to be welcoming back residents. The second feature provides an overview of Behavioral Health Services BEAM Navigator program, which stands for Bringing Expanded Access to Medications for Opioid Use Disorder, or MOUD. There's a lot of acronyms, I apologize. This feature highlights the nighttime telehealth pilot, which launched in March 2024. The pilot program provided individuals in the Tenderloin neighborhood with access to medical professionals and medication treatment between 8 p.m. and midnight. Since it began in March 2024, the program has facilitated almost 1,500 telehealth visits, with about 40% of those clients starting MOUD. The program was so successful that DPH is expanding and continuing it in fiscal year 2024-2025 and beyond. This feature also shows DPH's investments in expanding substance use treatment options and removing barriers to treatment. This work included launching new programs, expanding hours at outpatient treatment facilities, adding 400 residential treatment and care beds, and more than tripling the number of street care workers. As a result of these efforts, compared to the 2022-2023 fiscal year, SFDPH has seen a 32% increase in methadone treatment admissions, a 46% increase in buprenorphine prescriptions at the SFDPH Behavioral Health Services Pharmacy, and a 35% increase in residential treatment admissions. Additionally, the city saw an approximate 20% decrease in fatal overdoses in the first 9 months of 2024 as compared to 2023. The last feature showcases DPH's early implementation of doxycycline post-exposure prophylaxis, or DoxyPEP. Analysis from DPH demonstrated sharp declines in the number of chlamydia and early syphilis infections in San Francisco among transgender women and men who have sex with men after DPH released and implemented these new guidelines for DoxyPEP. the data showed about a 50% decrease in monthly infection reporting for these two populations. DPH became the first health department in the nation to release DoxyPEP guidelines and the first to measure the effect of DoxyPEP at the population level. The feature also describes DPH's presentation of these findings at the Conference on Retroviruses and Opportunistic Infections in March 2024. As of December 2023, over 3,500 people have been prescribed DoxyPEP in San Francisco. The early implementation of DoxyPEP highlights how DPH can come together, work in community, and implement innovative strategies to address our city's most critical health issues. Next slide. Following the features are 24 highlights showcasing work across the Population Health Division, the San Francisco Health Network, and Central Administration. The highlights speak to the tremendous work across the department in areas such as healthcare services, behavioral health, whole person integrated care, population health, the Office of Health Equity, and Central Administration, as well as at Zuckerberg San Francisco General Hospital. The highlights include key metrics and data following the Health Commission's suggestions from last year's report. The next major section of the report focuses on data, starting with DPH's budget. Budget data provides information on the expenditures by program and by type, revenue by source, as well as our major investments. For example, DPH's FY 23-24 budget included a focus on investments to support Laguna Honda Hospital and behavioral health infrastructure. The next data section highlights San Francisco Health Network data on visits, patient demographics, and payer type across the major systems of care. In FY 23-24, the network served more than 128,000 people across our clinics and our hospitals. This section also highlights how the network provides a wide array of services across the continuum of care. Unique patient or encounter data is provided for each of the service areas, including primary care, behavioral health, whole person integrated care, jail health, dental health, home health, emergency, specialty, and urgent care, as well as diagnostic and ancillary care. Unique patient counts, patient days, and average stay-in days for skilled nursing are also included for ZSFG and Laguna Honda hospitals. Furthermore, this section also includes patient demographic data by race and ethnicity, by age, by sex, and by gender. In addition, payer data shows payer sources at ZSFG and Laguna Honda hospitals, as well as within primary care and whole person integrated care. The report ends with an overview of the department's service sites and contractors. Included in this section are maps of the DPH primary care and specialty behavioral health sites, which have been updated to reflect location changes, and a list of our community contractors is provided as well. Additionally, each of the Health Commission resolutions adopted in 2023 and 2024 are included. Lastly, the report includes additional DPH resources, such as where to find more information on the Health Commission, where to get health coverage, and San Francisco's COVID-19, flu, and RSV response. I'd like to thank again all the staff at DPH for their collaborative work on this report, particularly my colleagues in the Office of Policy and Planning. And thank you for your comments, Commissioner Chow. I will incorporate your feedback and make the corrections to the final report. At this time, I am happy to take any further questions or comments. Thank you.
Thank you very much. Any public comment?
Is there any public comment in the room on this item? There is none.
Commissioner Guggenheim?
Yeah, I applaud you. This is an incredible document.
Speak in the microphone, Commissioner, please.
Oh, sorry. I really applaud you. I think it's an incredible document and it's filled with all kinds of information. My only question is, I don't know how to put this. What do we use this for?
That's a great question.
That is a good question. It is published officially and made publicly available. So it's available online for the public to access. Further than that, I would have to get back to you. Yeah.
Oh, yeah. So we do get a lot of questions like new board of supervisors, new commissioners, new CBO directors, that this is a really good grounding document for them to understand the scope and breadth of the department and also the things that we accomplished over the last year, as well as our staffing, who we serve, and where our funding goes.
I thought at one time we also were distributing it not only to the mayor's office, but to the board of supervisors for their information. Are we not doing that anymore?
A copy is given to the clerk of the board and as part of what we do, both to the library and the clerk of the board, and then they give it to the board.
So the board members are getting the copies because I think it's useful for them to understand the work that also the department is doing. Good, okay. Commissioner Guillermo?
I also just wanted to commend the writing of the report and the descriptions of, I know it's hard to put everything that the department does into one document, but you captured it well. I do have a question. So again, in terms of the communication and media, does the report go to any of the media at all?
Not to my knowledge, but once again, yeah, we'll communicate that. Yeah.
We can follow up. I mean, in my 15 years, this has been used kind of just as an orientation anytime we need it. So I don't think, I mean, and we'll get an official answer from you, but my understanding is that it's not sent out to media as it's published, but as needed in case the media needs to be oriented, they will send out something saying, a section or a page kind of thing.
Just it might be worthwhile since it gets published every year and there's new information and accomplishments and challenges that the press might not be as familiar with in the immediate when they're putting a story together. Yeah.
It might also be a consideration, I think, Commissioner, that the media may not really understand the breadth of the department and that there are things that, in fact, could be of interest to them or might actually be good background for them to understand the complexities of certain issues that sometimes come up and are very simplistically reported as if we should have been laser focused only on this and to be able to show the breadth of all the work. And in some instances, they may not even know it's the work of the department. Some of the work on environment and so forth. And it could be that a stray reporter might even just pick it up and be educated. But so I think there's great opportunity for its use for and over these years and certainly in the last several years, we've really continued to balance the issue of the text and program reporting with some of the data. With the data that you have. And you can look at my comments about, some of the small editorial issues that I have. We won't belabor everybody here with that. But I also compliment you as a worthy successor to last year's document.
Thank you.
All right. So thank you. This will be finalized and presented to you all, I think, in a meeting in April. I've forgotten which date, but the final report will be coming to full commission, so you'll see a similar presentation.
Okay, so this is your last chance to make any edits? Anybody? Actually, the last chance is at the commission, since now that it's online, basically, it's really easy to make final adjustments without feeling bad or throwing out 1,000 copies or something.
But we've all, including Director Seib, we've all heard your suggestions to possibly extend the audience of the report. I'm even noting the mayor's, the mayor himself, but also the mayor's programs to try to get private funding for certain things and to show what the DPH is actually doing. These pages sometimes can be helpful as well. Anyway, we'll carry those messages forward.
Very good.
And you did a great job. Thank you
Yeah,
for
thank
your
you.
first time presenting.
All right.
Oh, I guess we should ask for public comment, though.
Oh, yeah.
No, I did ahead of time.
Oh, you
And-
did?
and there is-
Okay.
there was
There's
still
no
a-
public here.
Yes.
Okay.
So we can move on to emerging issues.
Okay. Commissioners, any emerging issues?
Any,
No.
any public comment on that item? No public comment. We can move on to public comment. Any public comment in the room on general public comment? No. So a consideration for adjournment is in order.
Motion is in order.
Move to adjourn?
Second?
Oh, second.
All those in favor?
Aye.
All right, great. Please give me 30 seconds to take us down. Thank you all those who watched who will view this video in the future and all those who presented.
Thank you.
I have I don't understand.